My task today is to assess role or to present the role of physiology in left main and serious lesions scenario. Just to conclude the presentation of Professor Means, I would like to say that I really believe in imaging, but we still need physiological assessment in daily basis activity. We all know this very important paper published almost 30 years ago by Nico Pils with his idea to use just simple parameters to assess significance of coronary lesions. That what we have to take into consideration how many assumptions and simplifications we use just to come to this clinical usage of this idea. So we should take in our consideration that these simplifications and assumptions that resistance is not so important, it's stable, that pressure, venous pressure is also stable and not important, should make us very cautious and analyze the achieved result on individual basis, taking into account the whole clinical scenario of the patients. Anyway, this technique, based on pressure wire, exists, is available, and really tested mainly for 1 and 2 vessel diseases. But of course, in nowadays, with this kind of diffuse atherosclerosis phenotype, how we can apply these simplifications and assumptions to the serial lesions. We know from very important paper of second European father of FFR, Nico de Bruyne, that it's possible also with some assumptions, taking into account just 2 regular lesions. I don't want to go into the details. However, we should take into consideration that with the usage of FFR idea, we have to remember about cross-talking stenosis, about impact one on another. So just to be completely honest, we have to treat one of these 2 lesions, again assessing the first one, trying to decide whether we need a second stent. How does it look like on a daily basis? Here you have a 3 vessel disease case with a kind of diffuse or short lesions, but located very far away. And so what we have just distal value of this parameter, and we can believe that with the 1 stent or 1 lesion intervention, we can solve the problem. But it doesn't happen many times. In this paper was shown how does it look like in every single case. Just to be completely sure, we need a second assessment. It takes time. It needs adenosine, which is not well tolerated by every single patient. Today's talk it should be focused on left main, because for years with this left main we had a lot of hesitations whether we should use or not. And in case on isolated left main disease, it seemed to be relatively easy with distal LAD or distal circumflex artery. It should be taken into consideration the area of distribution, mainly LAD. LAD should be better because of bigger area of this distribution, and then pullback procedure showing whether we see increase on which level. So it works quite well. But how many cases with isolated left main we have in our clinical practice? Also, the meta-analysis showed us that this approach works. It's clinically validated, so we can use it, but only for this particular situation of isolated left main. Already, addition of one lesion in a downstream here, we really this is the merit of Dr. Ferron, that he showed us how only one additional lesion downstream can impact the results in assessment of left main itself. I don't want to go into the detail, but just to bring you the idea that was a usage of balloon in already stented LAD with the measurements in the circumflex artery just to assess the severity of left main stenosis. So it works, but based on this data, a couple of very important informations were distributed to us, that the influence of distal stenosis on the left main FFR depends on severity, myocardial mass. Downstream disease will cause overestimation and not underestimation of the left main FFR. So always perform FFR in a disease-free vessel, in this particular case in circumflex, just to have a point of confirmation and comparison. Also, based on this information, a kind of way of acting was proposed by this group. What I would like to say that, as it was also shown earlier, that when you have in LAD plus left main FFR below 0.6, you should perform IVUS, just to be completely sure how big is minimal lumen cross-sectional area. So in this situation, this is a combination of two techniques. So just to summarize this left main FFR business, so in single unit disease, FFR should be performed in both branches, and left main IVUS is recommended to assess the real impact of LMA, left main stenosis. In tandem lesions, so FFR pullback in both branches is necessary. The distal lesion should be treated firstly. So left main IVUS is recommended in case of treatment is needed. Here you can appreciate this, the case how the proximal and distal lesion was stented based on FFR results. And of course, FFR is not ideal. Now we have at least two, let's say, modifications of FFR here. This is a new parameter proposed by Nico Pils and Nico De Bruyne group. From ALST, pullback pressure gradient index, there is no time to go into the details. However, it seems to be much more precise and helpful for decision-making process. However, you need a special software. It takes time. We will see how does it look like in a clinical scenario. We are looking for clinical trials. In terms of IFR, this resting diastolic transgradient parameter is available right now with a very good correlation with FFR. It's much more impacted by the microcirculation impairment compared to FFR. It was tested in clinical scenario. Two big trials showed that IFR is non-inferior to FFR. And what is also very important that in terms of serial stenosis, this impact is not so. This information is much more easier to be used. There is no this cross-section talking, cross-lesion talking. I'm sorry. Also, with this pullback, we can estimate two phenotypes of atherosclerosis, focal or diffuse. trying to achieve, let's say, to send patients for the most optimal way of revascularization. This is also very, very good to have this option to localize the position of the stenosis. Here you can appreciate how you can manage with FFR and pullbacks of FFR, the final result, trying to get let's say to get optimal result. And of course, this is very important to localize on angiogram. Now, commercially available system of co-registration, where also with the system of software of virtual stenting, we can try to assess results taking into account number and length of the stents. Here you can appreciate this. And then just before my conclusions, I would like to show you our own results. We found that this IFR parameter with a cutoff value 0.899 works. We have very good results in terms of clinical assessment in 2 years of follow-up. In conclusion, I could say that today this physiological assessment of left main and serial stenosis is available, but I personally believe that due to some limitations, these non-hyperemic parameters today, IFR is mostly tested and proved clinically, is much better for clinical decision making. Thank you very much for your attention.